We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, ACHIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
Welcome back to the Infection Prevention Power Hour, where our conversations are as clean as our hand hygiene audits. Speaking of hygiene, did you hear about the bacteria who went to a party?
No.
Yeah, he was really into culture. Anyway.
Thanks, Jess.
We've got a star-studded panel of experts with us today, and we're diving into certification, mentorship, and the power of structured training for infection preventionists with their article, Enhancing Infection Preventionist Certification Success Through a Structured Training Program.
Absolutely. Yeah. And kicking us off is Kelly Holmes, MSCIC and FAPIC. Kelly's been part of Infection Prevention and Management Associates, IP&MA, Inc., since 2004, and she's been certified since 2006. She's got not only a wealth of experience across acute care, long-term acute care, and rehab facilities, but she also developed the comprehensive internal training process for the company that includes focused support for infection preventionists who are studying for certification. Kelly currently performs remote surveillance for several clients and manages a team of infection preventionists providing services to acute care facilities. Ms. Holmes obtained her FAPIC designation in 2024 and is a contributing author to the APIC text. She's got published abstracts and papers on training infection preventionists, interrelator reliability for surveillance, and she's a co-host for APIC's 5-Second Rule podcast. It's our sister podcast. Kelly, welcome.
Oh, thank you for that wonderful introduction, Nikki.
We're so excited to have you.
And wait, there's more. Joining Kelly, we have Jennifer McCarty, MPH, CIC, and FAPIC, who's been with IP&MA since 2000. Jennifer's certification in infection prevention and holds a Master of Public Health from the UT Health Science Center, Houston School of Public Health, after graduating from University of Texas at Austin with a BA in biology. Within IP&MA, Jennifer has developed epidemiologic surveillance systems, supported new employee training, and mentored new infection preventionists. She has overseen programs across various healthcare settings, including acute care, long-term acute care, and surgical facilities, and is well-versed in various survey methodologies. She's also held leadership roles in the local APIC Houston chapters. And let's just say, if you want to talk about epidemiologic surveillance systems or mentoring new IPs, she's your go-to. Jennifer, we're so glad to have you here with us today.
Thank you. I'm so happy to be here.
And last but not least, we've got Sandy Steinfeld, MPH, CIC, and FAPIC. Sandy's been a part of IP&MA since 1998. So if you do the math, she's basically a founding member of the Infection Prevention Avengers. Sandy holds a Bachelor's of Science from the University of New Mexico and an MPH in Disease Control with concentration in Epidemiology from the UT Health Science Center, Houston School of Public Health. She earned her certification in Infection Control in 2000. She is recognized as an APIC Fellow. Sandy has extensive experience in program assessment, policy development, regulatory survey preparation, and remote HAI surveillance across diverse healthcare settings. She's a published author, conference presenter, and currently serves as a senior associate in managing human resources at IP&MA. With a background in disease control and epidemiology, she's worked on everything from regulatory survey prep to remote HAI surveillance. Welcome to the show, Sandy.
Thanks for having us. I love that you called us Avengers. That was awesome.
Yes. It's a new mascot idea or a new logo idea.
This is quite the powerhouse trio. So let's dive right in. Kelly, let's talk about on-the-job training. How significant is it in achieving a passing score on the certification exam?
What a great question to start with, Jess. We can't speak to statistical significance as that was not quantified in this particular study. However, from experience, I do think on-the-job training tends to speed up the learning process by helping speed up the retaining of the information that a new IP is trying to learn. So what we do kind of see is IPs who are in the acute rehab setting, for example, that may not have HLD or a sterile processing department. They do have to devote a lot more attention to those aspects of studying for the certification for disinfection and sterilization. Whereas an IP that's in an acute care setting can do the reading and then walk down to endo or walk down to SPD and watch the process and maybe ask those questions that they've developed during the reading. So it is important, I think, for retention. It helps kind of speed up remembering the concepts. And then we also see it with like management and communication as well. So IPs that have been in the field a little bit longer seem to be a little bit more confident on those questions. So I do think it's very valuable.
Yeah, that makes a lot of sense. So, Jen, the article also mentioned that 78% of infection preventionists are nurses, with similar or smaller percentages coming from public health, and the laboratory backgrounds, about 8% each for those. Is there data that explains these distribution trends?
Yes, so as you know, infection prevention positions have traditionally been staffed by nurses. The data that we had, it came from the 2020, the APIC mega survey. And when we look back at the 2017 survey, we actually see a similar breakdown. It's a little bit different. It was about 82% of IPs coming from a nursing background and about 10 from the lab and almost 5 with public health background. So this shift that we saw in 2020 could reflect several different factors. One, there's currently a significant need for recruitment into the IP field. We know that there's about a 25% vacancy rate from the mega survey with a 3 to 6 month lag time to hire and train new IPs. So this definitely has been driving the need for an expanded recruiting pool. What we saw in some articles from Gilmartin and Reese was that despite that, across all practice settings, nursing continues to be the preferred professional background for new hires. We do see a little bit more coming from other areas if you look at large hospital systems or urban facilities. And this may be due to the fact that larger infection prevention programs have a better support infrastructure so they can mentor and train non-nursing background IPs. In contrast, when you look at rural or smaller facilities, these IPs traditionally may wear several hats. So they may be the infection preventionist and employee health, which would then require them to have a nursing background. And so again, it's going to kind of really condense that recruiting pool. We know that the knowledge and skill set that's required for infection prevention is expanding. We've seen this in the APIC core competency model. So definitely a need for a more diverse workforce is going to become a much greater challenge.
And that's interesting because I, as a old bedside nurse, learned IP alongside a microbiologist, lab guru. And Jess, you too are a micro queen. Is that correct?
Correct.
Yeah. So I definitely think that diversity was crucial to my learning. So I hadn't really thought about the fact that sometimes those additional hats might be what's limiting that. And I know that the article also discusses workforce turnover, something else that's really important to that area, especially with concerns about experienced IPs retiring. Kelly, let me direct this to you. Has any data been collected on the impact of these retirements on the IP field?
Well, data has been collected on the demographics of infection preventionists within their field. And their plans for the future. And then in the most recent issue of the Prevention Strategist, APIC's president noted that 40% of IPs plan to retire in the next 6 to 8 years, which is also in line with the projections from the 2017 and the 2020 APIC mega surveys. And then as far as impacts go, I mean, what do we know about turnover? A change in personnel can change the priorities and the vision for the program. Any projects that you have going on can slow down or halt altogether. So I think ultimately it slows down the collective progress of the program at your facility. But then if we're experiencing this nationwide, it will slow down the progress of the field nationwide. And as Jen mentioned, recruitment is time consuming, and then you have to put in the time to train your new IP. And so that can result in regulatory compliance issues, timeliness of mandatory HAI reporting, which could have a negative financial impact on the facility, as well as undetected outbreaks or patterns of transmission. But I do think APIC's done a fantastic job of characterizing this information and trying to get ahead of it with the development of their IP academic pathway, where they will partner with colleges and universities to design a certificate program, as well as that master's and bachelor level programs to prepare students for careers in infection control. And then I think once we get these brilliant young minds into the field, we need to focus on how to retain them in the field. And there's also some work being done there that shows, what people value within the field, which is, continued support for education, having some flexibility at work, that work-life balance, and opportunities for growth.
That's so funny. You were just kind of telling my life story right now. I have 3 pretty new infection preventionists at our academic medical center, with another one starting, I think, next week or the week after, that is also new. So this has definitely impacted the work that's happening within that group, because all of those IPs now need to be oriented, and that's takes a lot of time and energy. So other projects kind of have to go to the wayside.
Yeah, and it slows things down.
It does. And you think about the greater impact on healthcare, because these IPs are leaving other positions to take these positions, which are usually being filled by another new wave of workforce participants that need that same training and experience, et cetera, et cetera.
And it takes time, to gain the experience. Yep.
So speaking of novice IPs, in this particular study, 51 novice IPs participated in the competency-based training program, and 47 of them were new hires. So what types of healthcare facilities did the participants come from?
I'll take that one. This is Sandy. So you're exactly right. Most of our participants were newly hired employees. So 47 out of the 51 were newly hired employees and novice infection participants, preventionists, who participated in our competency-based training program. The participants came from a range of backgrounds, about 73% having no prior healthcare experience, meaning this was their first job. About 7% had a background in nursing, and about 6% had experience in public health. So our sample mostly consisted of first-time workers in the healthcare sector. And I think our results really demonstrate our program's ability to support individuals without a nursing background in developing their skills in infection prevention.
That's awesome.
Yeah, and Jen, I'll let you take this one if you don't mind. The initial training phase included orienting IPs to facility-specific operations, surveillance, rounding. So would that phase be adjusted in length or content based on facility type or size?
Yes, but what we've seen in general is that program management does have the same core functions regardless of the size. So for example, your annual document cycle, how you complete and report device bundle rounds, employee orientation, education, these tend to remain consistent from facility to facility. But what we do see is a change in the size and services that are offered by facilities. So a larger facility may have things like emergency departments, larger surgical suites, cath lab, endoscopy, whereas smaller facilities or inpatient rehab may not provide those services. And so we do need to customize for each practice setting. We do have to kind of change how we do the day-to-day practices depending on the size of the facility. Another thing that we make sure is the same across each setting is their proficiency and their NHSN surveillance. But of course, depending on the types of patients that they see, how we focus that NHSN surveillance may vary a little bit from type to type.
Mm-hmm. Yeah. What's the total duration of the program? What does a participant's involvement typically look like?
Sure. There are two components to the program. So the first part is the fundamentals portion, and that begins like the date of hire. And so then those IPs have orientation, and the orientation includes the training program. And so they're shown, their reading assignments, their quizzes, topic-specific webinars that they are required to watch. And then they have a list of skills for each module that they have to complete on site with their mentor. And that portion usually takes about 12 to 15 months. So once the individual has finished the fundamentals program, they immediately start studying for the CIC, which has an additional study program, which includes additional videos to watch, study guides, practice questions. And that portion of studying for the test generally takes people about 3 to 4 months. And so that might seem like an accelerated pace, but what we have found is that it's successful because our IPs have been exposed to the concepts on the test through the modules and then by applying it on the job. And so they're able to really be successful with that focused studying in 3 to 4 months and try not to drag it out too much, because if you're studying, over a 6-month period, you might forget what you learned when you were looking at the surveillance stuff, if you're looking at the management and communication. So we try to keep them on pace and on track so that they, get through it pretty much in the 90 days that it takes to register for the exam and schedule your exam out. But we don't, try to rush anybody. 3 to 4 months. Yeah, it's about the time frame that we see.
It's a really, really good approach. It's kind of like waiting a year to take the NCLEX after nursing school. You definitely want to get in there ASAP and take that.
While it's fresh.
Yeah, definitely. And so speaking of the CIC preparation and the materials, the article did note that the time that was spent on the training and CIC preparation wasn't tracked. Can you share any insights, or did you make any inferences based on the examination results as to like how much time people maybe were spending using those materials?
It is an asynchronous program, and so people are able to move through it at their own pace. And again, we hold them accountable, but we don't push, right? So, kind of referencing the above question, they take that, first 12 to 15 months to get really comfortable with the fundamentals. And then they're going to do that focused certification review for 3 to 4 months. People do have different learning styles, and they're encouraged to move at their own pace. Some pick it up so quickly and they're ready to certify like right at that 12-month mark. But some people just don't feel quite comfortable yet, and they, take a little longer, and that's fine. If you don't study for the test, your odds of passing it are probably not great. So it's really for that individual about understanding their own learning style and being honest with yourself. Are you a rusher? Are you a squisher? Do you memorize? Do you panic and you need a deadline in order to, produce results? And all of those styles are fine, but we really take people through and try to understand, like, hey, here are some different styles and here's some strategies to cope, based on how you learn.
Yeah, knowing your learning style and your test-taking style, knowing all of that is critical to all of those certifications.
Oh, for sure. And people are really hesitant to be like, well, I cram. Like, they don't want to admit it, that they're a crammer. But I'm like, I'm a crammer. Right. I need a deadline, and somehow that lights a fire. So let's talk about, if you are a crammer, here are some tips, to help you study.
Right.
Yeah. I'm definitely a crammer.
Yeah.
Are you?
I know.
No, I need 4 years to study each small detail for hours a day. And of the CIC, CPHQ, of all the certifications that I've got, I think the CIC was the hardest. I applaud you all for being crammers.
Oh,
I
that's
admire your
interesting,
brains,
Nikki.
but I could not have crammed for the CIC for sure.
Well, we don't promote cramming. We just promote being honest. If you do have a cramming type style, let's, break it down. Those people need due dates. They need to break down each section. I'm going to take this long to study for each one, and here's my process for doing so. And just that and talking it through can be really helpful to people.
Right.
Yeah.
I mean, I think it took me a couple of different examinations to figure it out. But I was like, I'm definitely a crammer. I need that deadline so that I know I have 2 weeks to really let this sink in. And I know how the material absorbs the best. And then when I go to take the exam, I also know that I might start going back through and looking at those questions again, but I'm probably going to just panic and just submit it before I'm done. Yeah, I just want it to be over.
Yeah.
So true.
It's funny that you guys are crammers. I think I'm a prepper. I don't cram. No, I think I definitely had a lot of preparation for that first exam.
Well, you know what?
Well, you did it right.
And we need that diversity, right?
Yep.
So let's talk a little bit about the education of the participants as well. So 39 of the 51 participants actually had master's degrees. Do you think that the educational background contributed to their competency of IPs, or maybe not?
Yeah, definitely. In infection prevention, we have people with, actually on the call today, right? We have people with masters in public health. That's me. That's Jen, and that's Kelly. And then Jess, you said you're a microbiologist, right? And Nikki's a nurse. So we all have strong skills, and every background brings a different strength to the table. But we found that everyone benefits from supplemental knowledge from other competency domains to be successful in this role. Likely, the MPH education of our participants contributed to their competency. A master's degree typically provides coursework in advanced critical thinking, research skills, and specialized knowledge in public health, all of which are valuable in infection prevention. Many of these graduate programs emphasize analytical skills, problem solving, and understanding of healthcare or scientific principles, which can enhance an IP's ability to interpret data, develop policies, and respond effectively to infection risk.
Yeah, absolutely.
Kelly, do you think that there's a correlation between IPs with certification in infection control and the effectiveness of their programs?
I love that you asked this question. I feel like it's loaded. And in the research, the certification board did conduct a marketing research study to determine the perceived value of certification among infection prevention professionals and other stakeholders within facilities. So respondents stated that certification demonstrated professional competency, increased career growth, improved regulatory compliance, was important in influencing legislation, and improved the practice of infection prevention and control. So I think there is evidence that supports that certification will help you have a more effective program. But I think we can't talk about an effective program unless we also talk about appropriate staffing for the program.
Right.
Even a certified IP who's not set up for success with their resources will struggle. And then the recent paper from FAPIC's Center for Research, Practice, and Innovation, which was really awesome, used the staffing calculator and CMS SEERS. And what they determined was that nearly 80% of hospitals had lower staffing than expected. And those hospitals that had the lower staffing reported higher standardized infection ratios for CLABSI, CAUTI, C. diff, and colon SSIs. So that's, pretty powerful information there.
Yeah, very telling.
Yeah.
Yeah, and a lot of infection preventionists, as we mentioned earlier, may be in those dual roles or be working independently within their facility and don't really have opportunities for mentorship and training due to resource constraints. Do you see this CIC education and training program being developed into a national or even global program?
That is definitely a very real scenario. I think for a lot of IPs, you're the lone IP and expected to be the subject matter expert from day one. Our model actually has been successful with IPs that are in remote locations where travel wasn't always feasible or frequent visits weren't, available for a mentor to go and be, on site with a person. But we've been able to tailor the course with additional support and coaching and accountability for them to be successful with certification. So currently our program is a niche training program and we customize it to the IP and the facility. But we're expanding to provide that remote asynchronous training option with mentorship available through our website. So we're hoping, that we can expand it so it'll be available to people in those remote locations if they choose to use it.
That would be great.
That's exciting. Yeah, that's very exciting. And let me lob this to you, Jen, if you don't mind. Can you expand on how those mentorship models, especially near peer, contribute to higher pass rates in structured training programs?
Yes, and I actually love this question because it really strikes at the heart of kind of what I do on the day to day. So, with our mentees, when they're getting into that didactic portion with the training and their modules, it can be really challenging for them to see how these different concepts are going to fit into kind of overall program management and to a lesser extent, how this is going to roll into when they eventually take the exam. So, one of the things that the mentors and or the near peers will try to do is in real world scenarios show them how here is this actual event taking place. How does this apply to a particular module that they might have done? And then also how that can relate back to the examination. And as they're going through these different experiences, what we've seen is it does help them remember and reinforce some of these concepts. And so then when they are taking the exam, they can pull on this. And we, again, try to tie all of that together, both the didactic. I do remember that piece. I remember actually going through the actual process. And then now I'm kind of looking at it on this exam and can kind of relay that when I'm taking it. And I do think that that's really helped them, especially with some of the more esoteric concepts that are out there.
Mm-hmm. Yeah, it's a really smart approach. So on behalf of the IP world, we thank you. And let me ask you, Sandy, how can smaller healthcare systems or those rural facilities with limited resources replicate the program's success, particularly in terms of mentorship and support?
Yeah, it can be difficult in those if you're in a small healthcare system or even a rural facility where you have limited resources. Really, what you want to do is leverage external mentorship and support networks. And so, one effective approach is partnering with professional organizations like APIC and SHE, both of which offer formal mentorship programs. These organizations connect novice infection preventionists with experienced mentors who can provide guidance on best practices. Additionally, smaller facilities can identify in-house experts or senior staff to act as mentors. And this might be something that you would want to do in a department like sterile processing or maybe the operating room. And so providing this structured time for these senior members to share their experience and knowledge can really create a really great supportive learning environment. Facilities might also utilize remote learning opportunities. So, for example, webinars and virtual training. And again, groups like APIC, SHE, and even our company, IP&MA, offer these services. And so you have this combination of external mentorship, internal support, and access to remote resources really can help smaller healthcare systems successfully develop competent IPs despite having limited local resources.
This has all just been really fantastic, and we want to give a truly heartfelt thank you to Kelly, Jennifer, and Sandy for spending some time with us and imparting your infection prevention wisdom on us today. We just want to ask if you have any last takeaways for our listeners today.
Oh, thank you. I think that we're in such a fascinating time in the field with the new concepts that are available, the new technology, artificial intelligence, where the field is moving. And we're really poised for tremendous progress in infection prevention. So we just need to support bringing in those diverse backgrounds and helping them to be successful, and people who've been in the field for a while to support them. Yes, you can do this, get the certification. And I'm excited to see what the future holds.
Yeah, it sounds like a great opportunity also for APIC chapters to seize on, depending on the resources. So, yeah. We'll try to keep things as clean as your program's going forward. We are so grateful that you guys were on. We really enjoyed the conversation, guys. Thank you so much. And as I like to say, that's a wrap. Thank you for joining us today. We are Nikki Shore and Jesse Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
AJIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Center of Research, Practice, and Innovation, and Pat Stone and Jean Brandt at AJIC and APIC staff, Rebecca Bartles, Ria Gupta, Bobby Gulshan, and Liz Garman. We work in partnership with Human Factor and audio techs Blake Alton and Carolyn Schneer. To hear other AJIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, ajicscienceintopractice.org. That's AJIC scienceintopractice.org.